How does it differ from private practice?
It's a huge difference. India is doing around 15 to 20,000 transplants per year.
How does the coordination happen between the ICU and organizations like NOTO, SOTO, and ROTO?
Process which has actually undergone a huge change.
What role do these transplant coordinators play in this whole complex process?
Transplant coordinator is a very wide professional.
What are the ethical dilemmas that surgeons tend to face while balancing the need of multiple patients on the waiting list and the donors?
Transplant itself is a entirely, it can be a textbook of ethics in transplantation.
Organ donation isn't the end of a life, it's the beginning of many. Hello, I'm Navya Mrig, the founder of Saahas, an NGO dedicated to raising awareness about public health issues, including organ donation. Welcome back to another episode of Saahas Stories, where we share real experiences from real voices from the world of organ transplantation. Today, I'm joined by Dr. Nitin Agarwal, Professor of Surgery and part of the transplant team at Ram Manohar Lohia Hospital in New Delhi. Currently, RML Hospital is doing kidney and heart transplant and is also working towards doing liver transplantation in the future. Welcome, doctor. Thank you for joining us here today.
Thanks so much.
Today, we'll be talking to him about the challenges faced in a government setup behind such life-changing surgeries and the issues he faces daily. So, firstly, doctor, could you just tell me a little bit about the experience of working in a government setup as a doctor who performs transplantation surgery? How does it differ from private practice, and what are the common issues that you face?
So first, I'd like to congratulate your initiative and
Thank you so
from the
much.
previous podcast, which we're doing a wonderful job of educating the public, which is the need of the hour. Regarding the question about differences from government, and it's a huge difference. So if we know from your previous knowledge and our previous episodes that the numbers tell the story themselves. Transplants currently in government hospitals are around 1/10 of the numbers done in private hospitals. We are doing in absolute numbers almost the third most transplants in the world. India is doing around 15 to 20,000 transplants per year, which is a good number. But where we lack is that our numbers are skewed. The numbers are very few in government hospitals where the patients really need the transplants,
Okay.
and they are located in specific private centers. We cater to even foreign patients, but we're not able to cater to a large part of our needy population. So the problems in our public sector is that there are general problems and there are transplant specific problems. Generally, you know that we cater to, government hospitals cater to all patients in preventive health, in tertiary care, the entire gamut of health services. So transplant patients have to unfortunately compete for those services. They have to, stand in long queues for the pre-operative workup and, dates for all the basic investigations, which is not really ideal because they need to be worked up quickly. And we have to compete with other serious illnesses like cancer and so many other serious health issues, so government hospitals are actually catering to large segments of population who are economically disadvantaged.
Right.
And they anyway are, at the receiving end of so much of personal, physical health problems, economic problems.
Right.
In that, when it comes to transplant, the specific requirements are requirements of infrastructure,
Okay.
operating theaters, transplant teams, multidisciplinary care. Again, those services can be challenging in public health services because it needs organization, it needs resources. And we haven't still done that very perfectly, from the administrative side. That's why we are doing so few transplants as far as the number is concerned. For if you talk about kidney, we need about 1.5 lakh transplants a year. And in government hospitals, we are doing hardly 1,000 or maybe just 2,000. So you see that, how skewed it is. And then if you come even later, if you talk about even more specific things, there are immunosuppressive therapy,
Okay.
which is around 15 to 20,000 rupees per month for kidney transplant and other transplant recipients for lifelong. That is a critical part of, transplant care and transplant outcomes. That is also costly for the average person, and that is still not covered in so many government schemes. So in every way, the transplant is a challenge in a public health setup. Even attending the OPD in the post-operative period in a crowded place, the first thing about transplant, after transplant, is that you need to avoid crowds because they are immunosuppressed and they can catch infections.
More risk.
Yeah, so they are not supposed to, and then when they have to come to show themselves in the crowded clinics. So you can see that every stage for a government hospital doing transplant can be challenging.
Yes.
So I think the crux of the matter is that we have to identify these problems and communicate them. They're already in the process of, building capacity, building infrastructure, development of, professionals, cutting down the training to a more finite and optimum level so that we can, have more and more transplant professionals, surgeons to cater to patients who really need the transplants.
Yes.
So that is the need of the hour, actually.
That's a really interesting perspective because I think most people judge organ donation by the face of it and often tend to ignore these deeper issues that are actually such a big deterrent to transplants happening in our country. So, how does the coordination happen between the ICU and organizations like NATO, SOTO, and ROTO?
So it's a process which has actually undergone a huge change. Uh, Even up till the late 90s, there was no central law governing the process. And then there are a lot of clandestine operations which you might have read about and even still happen, unfortunately.
Yes.
And this had to be sorted out, and it was an act of parliament, the Transplantation of Human Organs and Tissues Act, the THOA, it was called in 94. It underwent some revisions, changes. The latest version of the act is in 2014, which now makes transplant very, very open, fair, and a very serious activity. And this actually envisages that there is a central organization called the National Organ and Tissue Transplant Organization, the NATO.
Yeah.
The main office is in Safdarjung Hospital in central Delhi, and they overlook the administrative and the allocation and the monitoring part of the entire part of transplant. They keep a central registry, and they also oversee the work and the function of regional organ and tissue transplant organizations, the ROTOs, which are mainly the peripheral aims. They have been designated as the ROTOs, and there are state level organizations also. So by this organization, a lot of uh, central monitoring can take place, and a lot of streamlining has occurred. At the level of each hospitals, now there are complete transplant hospitals which are registered with these organizations, and there are only retrieval hospitals which can do deceased donor retrievals from patients who have undergone brain death, but they are still not starting transplant recipient surgery. So these retrieval hospitals also come in the ambit of these organizations.
Right. So, what role do these transplant coordinators play in this whole complex process?
Very good question. That transplant coordinators are central to this process of coordination. See, transplant coordinator is a very wide professional. They have purposely been, uh, you know, kind of envisioned to be providing care which neither the doctor nor the nurse nor the administrator can provide. So they have a very wide role, and they are drawn out from, a very they have a very broad list of specifications. They can be either biology students or they can be, science students, and they have been given these roles of, transferring information from the hospital to the NATO or ROTO, wherever. So when where do the transplant uh, donors come from? They are mainly two types of donation. One is living donor donation. We call it LDOT, living donor organ transplant, in the current scheme of nomenclature. And then we say DDOT, or deceased donor. We don't say cadaver anymore because it's not a very respectful term.
Terminology
Terminology and nomenclature is very important in transplant. It takes so much of just like now we have in other contexts, we never say handicapped anymore.
Right.
We say differently abled, and we have all these better terms for things,
which can make a big
difference
in the perception.
Yeah, perception is important. So when we have a deceased donor organ transplant, they can be either after brain death, which is called DBD, or donation after brain death,
Right.
or it can be donation after cardiac death, which is DCD, which is not very common in our country yet. So once a brain dead donor is imminently identified in the ICUs, in the hospitals.
Okay.
The transplant coordinators are already on the job. They are monitoring the ICUs every day. In fact, many times a day. They have these lists where they are seeing which are the imminent deaths, which unfortunately medical science will not be able to save.
Right.
And that is where they start, they have their task cut out into scientifically into many categories. They identify, then they have to break the news to the family, and they have to make sure that the family understands the irreversibility of the process.
Yes.
And it's a very difficult and emotionally challenging task, because to make sure on one side that they are being honest, and also to make the other person believe that there is no conflict of interest, that the care will be given till the patient has any small iota of hope or survival. So that is a very challenging, and that is where most of the dropouts or the conflicts happen. The transplant coordinator with experience learns to overcome these difficulties and bring some patients on board with the reality of brain death, and then subsequent, because the time is, in a sense, the time between the imminent death, actual brainstem death, which is declared by a brainstem death committee, and then retrieval of the organs is quite short.
Yeah.
So brainstem death is death, it's irreversible, but it also leads to acceleration of other organ deaths if not intervened on time. You have to make sure that the organs are retrieved, they are provided some support, medical support. It's not that brain death means organs can carry on indefinitely on their own.
There's a very small window.
Very small window. And this window has to be exploited, in the sense medically, as well as the other legal and ethical and emotional challenges have to be tackled in that small window. So that's where the transplant coordinator is the most active. And once there is brainstem death declaration, which is needed twice at the level interval of 6 hours, and families on board, all the paperwork is complete, that is the time when we are sure that we can use those organs. I'd also just like to add that once we have the brainstem declaration, there is also NATO also does a very important role of uh, keeping an allocation list by certain criteria. Now, this is a recent development in India, that we have now centralized allocation criteria, which can't be breached by anybody. So it is NATO's decision to allocate on priority the organs to the various recipients, to the hospitals. In fact, government hospitals get some priority in this regard because they have patients who are poorer and more needy. If the retrieval is happening in a government hospitals, then some organs will definitely go to that hospitals, provided they can use it further. And this is also where NATO comes in very importantly.
You're absolutely right. These transplant coordinators tend to play a really big role and can change the outcome of the entire process. Previously on Saahas Stories, we've spoken about kidney transplant, which is one of the leading transplants that happens in India. And liver is one of the other types of transplants that can happen with a living donor, which most people actually don't know about. So, could you explain this process of getting a part of the organ from a living donor?
So yes, actually transplants, they differ among themselves. So the common solid organ transplants, like you said, are the kidney, heart, liver, some now even small intestine, pancreas. But amongst these, the kidney is probably the most common transplant overall, and also can be done in living donors relatively easily, because you have one kidney which is separate from the other, and the operation is relatively straightforward. It has its own risks, definitely. Liver is another organ which can be taken from living donors, but it's a really big deal. A living liver donation is a huge medical and ethical, and see, because living donor transplant per se is ethically challenging. First aspect of medical science is primum non nocere in Latin, which means first do no harm.
Okay.
So the patient has to have a disease, and that is why you're taking the risk of any medical treatment. For a donor, he's actually a client, he has no disease. So, to do something of risk on him is anyway ethically challenging. And for this challenge to be overcome, it took many decades of research and legal hurdles to be overcome to allow ethically living donation. And it's particularly challenging for liver, because liver is a very vascular organ. The operation is challenging, risky. It has its own morbidity and mortality.
That's right.
And it has been overcome now after a lot of medical breakthroughs. But it took time. It took 10, 20, 30 years for this operation, the living donor operation. Because, see, now, if I, as an adult patient, I am 100 kgs, so I need around a kg of liver to survive. If I'm 60 or 70 kgs, I will need 600 grams of liver. Where will I get 600 grams from? Another adult patient has just about 1 kg of liver. So he has to donate 65 to 70% of his liver for the recipient. You imagine the gravity of the task.
Right.
And why is this possible? Because the liver is the only organ which can regenerate. So if you are left with 25% of liver, which is healthy, and you are otherwise also healthy, this will regenerate to almost its full capacity in a few weeks. So that makes it medically possible for us to actually carry out liver donation. We can retrieve 65 to 70% of the living donor's liver under very tightly controlled circumstances. So we have to identify in the living liver donor that there should be minimal fat in the liver, which we call as fatty liver nowadays. It has to be a healthy liver. You, the donor cannot be overweight. The BMI has to be tightly controlled. It can be, not more than 27, 28 BMI.
Okay.
Many other, parameters are identified. No other disease, no other uh, intake of any toxins or substances. So many other tightly controlled situations. Almost a perfectly healthy person can donate this much liver. And how does this actually work out? So I'll give you an example. So who are the profile of the liver recipients and the liver donors? And you'll be able to appreciate how ethically and medically challenging this is. So the typical liver transplant recipient in any hospital in our country is a middle-aged man. Mostly men are affected by liver failure. He would have a history of alcohol intake. That is 50 to 60% of the etiology. So alcoholic middle-aged male, okay, who has lost his liver function and who comes out as the eligible donor after all this medical workup I told you. Mostly it is a young, healthy, relatively fit, unmarried daughter, because the males would also tend to be a little overweight. They sometimes not qualified to be donors. And anyway, in our country, living donors in kidney and liver are mainly women. Women have a very caring outlook, and they, are the first to step forward for their families.
Yeah.
So you have an unmarried, and why is the mother not donating? Because the mother would be herself crossing the very,
Age limit.
age limit, which is very tightly controlled. She would be more than 50 or 55, maybe not have that healthy a liver. So the real scenario is that we have these pairs of, uh, you know, alcoholic male father and a young unmarried daughter, and it poses so many ethical and emotional challenges, and that is why living the liver donation is a really big ask,
Right.
and that is why we have to stress on increasing the deceased donor ratio in our country, which is presently not more than say 10 out of 100 at the best of circumstances. We have to increase it because so that we can avoid these ethical situations which we
Even
face.
lower, I'd say.
Even lower, it will
Yeah.
help, yeah.
Yeah, so I completely agree. This whole process of transplantation of the liver is really complex. So, what are the ethical dilemmas that surgeons tend to face while balancing the need of multiple patients on the waiting list and the donors?
So the ethical transplant itself is a entirely, it can be a textbook of ethics in transplantation, because it, like I said, it starts from the violation of the first moral code, which
Right.
Hippocrates and others, put forward in the early part of history, that primum non nocere, that is violated in living donor transplantation from the outset.
Yes.
We are touching a patient who has no disease,
Mm.
and we are putting him to potential harm. So this is the first challenge. But yes, it was overcome with research. They showed that if a patient was a living donor, what were the benefits to the patient, potential benefits? One was obviously that his family member would get well. So there were psychological benefits.
Yes.
One was an altruistic benefit.
Mm.
Altruism is a sense which, talks about giving,
Mm.
which in our scriptures also, when we give,
Right.
We face, we get some feel good factor behind it, and we, feel good, and we psychologically we benefit from it. Our own health indices go up. So these have been proven now. These have been proven that there are medical and mental health parameters which improve after donation. You feel better about yourself. You feel participatory in the process of, healthcare in the your country, your society, your family. So these are the benefits, and there are many other ethical challenges. They differ in deceased donor transplantation and living donor transplantation. In deceased donor transplantation, there is a main issue of, dignity of life during the process of organ allocation, during the process of organ retrieval. Like I said, terminology and nomenclature play a big role. Then it is the fair allocation criteria. You can have, uh, you know, influences of money, wealth in these situations, which the administration has to solve.
Right.
There are still cases which come to the forefront, but those are few, and hopefully with the right laws there. Then you have, sometimes futility. As a we sometimes feel that it's futile to offer something. So those are something like euthanasia as a concept. Similarly, in transplant, you may not feel that this is going to do any good. So those are some of the ethical issues in deceased donors. In living donors, a separate set of issues.
That's right.
Like I said, that uh, you can have a situation where there is trafficking of organs.
Yes.
Because
That used to be common earlier.
yeah, because there are people differ in their the power they wield in society. So people who have more money, but unfortunately they fall sick, so they might want to buy their way through health services, which cannot be allowed because it has so much of implication on the entire health system. It is a norm in many countries to have paid donation. I'll not name those countries, it's all over the news, but it has not really been a very good experiment. It has led to its own problems.
Yes.
And I think that these things have to be altruistic. And laws in our country are also very well designed. Yes, they are very stringent. Presently, the laws are very open to donation from living near relatives who are blood relatives, mothers, fathers, sisters, even grandparents. But they become a little tight for, more than first degree relatives, like it for aunts, for friends, for distant relatives, because, there are implications of exchange of resources in those situations, which is a reality.
Yeah.
And the law has to make sure that these things don't happen.
You're right. I think these laws are there for a reason to ensure that improper use of organs doesn't happen, which defeats the whole purpose of
Right.
organ donation itself. So, in continuation of this, could you share a memorable story of an instance of transplantation that really struck you?
So when I was speaking to you, I go back on the transplants that have happened in my own experience. Almost every case is like a story, because it involves families, it involves decisions. There was a mother who was old and her daughter needed a kidney, and there was some problem with her kidneys. So she said, "You take both." Those are the kind of emotions that, and you sometimes don't know how to deal with those emotions. We can't take both kidneys, obviously. The donor has to have as much priority for us as the recipient. But these are the kind of emotions that come from patients. There was also a story many years back when we started our deceased donor program. So we were looking very, a lot of enthusiasm for hospitals to give us deceased organs. And we came across one night, one case where there was a liver transplant recipient who was very young, a young boy who had received a liver from his mother, part of the liver.
Right.
He was doing well for a few hours, then unfortunately had cerebral edema. And the liver transplant recipient was unfortunately declared brain dead.
Oh.
Now, because this family was so exposed to all the transplant emotions and all the transplant challenges, they came forward with the idea that, somehow you use these organs that he has left behind. You use the liver again you use whatever you can, and he will, he can contribute to society. They had already gone through this themselves, so they were aware. They were, they could empathize with other patients. So the liver, of course, could not be used for technical reasons, though there are reports that reuse transplant can occur.
Right.
But the kidneys were offered to the other hospitals, and people were very wary. This has not happened so frequently before.
Quite
So,
rare case.
very rare. So, like I said, because we were needy, we were enthusiastic, we took both the kidneys in our hospital and we implanted them into two recipients who are doing well even after 10 years today. So that remains a very memorable instance for me, a reused transplant from a donor who was himself a recipient and going through the emotions of that family. So that was very challenging and very memorable for us.
That's really interesting.
Yeah.
It's amazing how you were able to continue um, their life by transplanting their organs. So, how do you and your team handle the emotional aspects of interacting with the donor families, since we know that this is such a touchy topic?
So, like I said, it's not only touchy, it's also legally very tightly controlled. So, as a transplant surgeon, as a transplant professional, by law, in deceased donor transplantation, we are not supposed to interact with an imminent death or a potential brain death family. It's not our job. The roles have been cut out. So this is the transplant coordinator's job. The minute we start getting involved, it opens up so many questions about conflict of interest, and correctly so. If I was on the patient side, it would be very difficult to believe that my patient has not been given the entire benefit of medical treatment just for the want of his organs. So it's a very tightly controlled process. So we are not really involved in that situation. We are involved with the recipient and in the living donation, to talking to their families when they come
Right.
to us during the evaluation process. Sometimes the donor has issues. We can offer something called as a medical alibi, which is also an interesting concept I like to share with you. That, like I told you the example about the father and the young girl. Suppose there is a sibling or a daughter or a son who is, who has his own family and who is not very sure about donation, but doesn't want to say no because he wants to contribute to his father. So what does he confides to the doctor that,
Okay.
I am not very sure, but I can't say no to my father. So what do you do in that? There's nothing written in the law in that situation. So what we can do is we can offer him a medical alibi. We can pick out something which is not ideal in his reports and give him that reason, so that emotionally he also can justify to himself that I opted out because of my own health and I was not allowed by the doctors. So that's where we can get into the, but it's better if we stay out of family dynamics, and
Okay.
it's not such a well defined process, I would say. But case by case, we try our best.
That's really
So,
interesting. I
yeah,
was unaware that
yeah.
this kind of service was available. So lastly, doctor, what message would you like to give to young medical professionals today related to this whole topic of transplantation and organ donation?
Medical professionals, I mean, who are already pursuing medicine or nursing, or I would say that they're mostly needed, in my opinion, in the transplant setup. Like I said, especially in the public care hospitals, public health hospitals, we have a dearth of professionals there.
Right.
They would be best suited to being transplant physicians, transplant surgeons, pathologists. We need lots of them going forward. Yes, this what you're doing, like education and awareness and building trust and building. This is also very important. People can get into this area, and basically every day you kind of educate somebody and you try and. But the people who already come into the medical science, I would prefer that they actually get into the transplant activity. That's where they're needed the most. But yes, it is a very tall call. It needs hard work, it needs involvement. There is long hours, long years of study. It is any specialty that you pursue which involves patient care is not an easy decision to take. So,
That's really interesting. I think we should also bring to attention the paucity of doctors and surgeons when we're thinking about what deters the rates of organ
Very
donation and
important, yeah.
transplant in our country. Thank you so much, Dr. Nitin. It's been a really insightful session, and it's amazing to hear how such life-changing surgeries are happening in our country. And hopefully, in the future, we'll be able to increase the rates and the numbers through our efforts. So, thank you so much for being part of the cause and joining me today.
As a last part of our conversation, as for any transplant conversation, I think we should also talk about the Form 7 on the NATO website. It's basically a organ donor application for
Yes.
all of us. And I always do that whenever I talk about transplant at any
Mm.
forum. The last part should always be about looking at the NATO website, looking at Form 7, and pledging your organs to the good of society. It is a basic duty for every citizen of India, and I would like to end with that if you permit.
Yes, I think that is what our viewers should take away today. If this session inspired you even a little bit, you can go to saahas.live, where our website has a form for you to sign up to be an organ donor. And with our collaboration with Organ India, you'll get a donor card which you can display and talk about with your family and friends to spread this cause and play your role in this issue that we're facing today in our country. And of course, you can find out more at my website as well. If you have any doubts, any myths, any misconceptions, then you can find out more about that at my website as well. Thank you so much for watching this episode today.